This is our 24th lecture this year, and we are in the second month of our endometrial cancer module, and this will be the last month on endometrial cancer.
Third month.
Today we have a very في حاجة?
It's the third month.
The third month endometrial cancer. Oh, I'm sorry. Okay. So we have a very special lecture with a very special one, Dr. Mohamed Hamdy, our senior lecturer of surgical oncology. He will speak today with us about uterine sarcomas. I hope this will not be a too long presentation. And the floor is yours, Mohammed.
Hello everyone, Mohamed Hamdy. Hello everyone, I'm Mohamed Hamdy, lecturer of surgical oncology, Mansoura University. Today we are going to discuss uterine sarcomas. Please feel free if you have any question during the lecture to raise your hand and ask your question in the Q&A box or the chat box. Regarding definition, uterine sarcomas are a group of disparate, highly malignant cancers developing from the uterine corpus. Regarding the epidemiology, it consists about 3 to 7% of all uterine cancer, and it's about 17 per million annually. But actually, nowadays, especially in our center, I think this epidemiology and this percentage is going to be raised more than that. We face or encounter cases with uterine sarcoma. I think yearly it's increasing. So regarding the risk factors, actually there is no causation or actual causation that can cause uterine sarcoma, but they found there is some risk factors like patients who received pelvic irradiation in about 20% of cases, in patients with history of tamoxifen use, and in some cases with in some race, like in black women. Regarding pathology, there is many and differentiation and many classification regarding uterine sarcomas. But the most common types are the leiomyosarcoma, the endometrial stromal sarcoma, and undifferentiated stromal sarcomas. There is also other rare mesenchymal sarcomas or mixed types like adenosarcomas, perivesical epithelioid cell tumors, rhabdomyosarcoma, and I like to insist that carcinosarcoma is not categorized as a sarcomas. They are treated with the uterine or endometrial high-grade epithelial tumors. Another classification of the pure uterine sarcoma, not the mixed one, like WHO classification. They divide the uterine sarcoma into smooth muscle tumors and stromal tumors. The smooth muscle tumors, like the benign one, like leiomyoma, the most common type, and in between leiomyoma and leiomyosarcoma are the smooth muscle tumor of uncertain malignant potential. It's called STUMP. This STUMP, like when you encounter patient with borderline ovarian tumors, it's in between benign and malignant. And the stromal tumors, over the years, the stromal tumors have many differentiation and classification, but nowadays they classify this types of tumor into endometrial stromal nodule and low-grade endometrial stromal sarcoma, high-grade endometrial stromal sarcoma, and the undifferentiated uterine sarcomas. Regarding the clinical background or how to diagnose cases with the uterine sarcoma, actually it's a challenge. Most of the cases were diagnosed at after hysterectomy or myomectomy. Most of these cases are diagnosed at this position. After you do the hysterectomy or myomectomy, you face that your patient had a sarcomatous element in this tumor. Most of patients have no clinical criteria that you can suspect malignancy. Most of them have vaginal bleeding, a mass maybe protruded through vagina, abdominal fullness, pelvic pain, urgency, and constipation. All of these are common with any gynecological problem. You can diagnose by biopsy, sometimes during the most often during surgical removal. And regarding DNC, it's have a limited sensitivity for sarcoma. There is no preoperative test that you can reliably use it as a for diagnosis of sarcoma, preoperative for sure. Some studies showed the rule of preoperative needle biopsy, but it's still under clinical trials. There is many concerns regarding the intraperitoneal disease dissemination. Please do not refer patient for doing such maneuver unless it's if you have an large uterine mass unresectable, you are going to give her the chemotherapy or chemoradiotherapy, and you are suspecting for sure that is a sarcoma, you can go for the transabdominal or guided biopsy. Also, it can be done through transvaginal biopsy. Regarding the radiological data, you can how to suspect uterine sarcoma. Most ultrasound or MRI, there is no pathognomonic image, but there is some features you can suspect sarcoma during doing MRI or ultrasound. In ultrasound, if the mass is large enough, it's solid with increased peripheral vascularity, there is degenerative changes. Actually, degenerative changes can occur also with leiomyoma, but necrosis is one of the criteria of leiomyosarcoma. Also in MR feature, you can see if there is ascites, associated ascites, if there is endometrial thickening. These lesions always are hyper intense in T1 or T2 weighted images. These are criteria that you can suspect a little bit, but in if there is another predictor, yes, some studies showed the role of LDH. You can use the LDH as an indicator for malignancy. It is raised or doubled in cases with leiomyosarcoma. You can suspect regarding the age. If you have a patient with recent old in age and have a recent mass like leiomyoma in the uterus, you can suspect that this lesion is leiomyosarcoma. Also, you can add with this the doubling size of the tumor. If you have a patient with history of uterine mass like leiomyoma, but it's become double in its size in 3 or 6 months duration, you can suspect also that is leiomyosarcoma. Okay, regarding the staging, actually this tumor is the stage related to the size of the tumor. But there is one pathologic type of the tumor is not related to the size, is the adenosarcoma. Adenosarcoma, because it's related to the uterine cavity or endometrium, it is the staging of this type of the tumor by the invasiveness like endometrial cancer. Take the endometrium, myometrium, more than half myometrium or more than half the myometrium. But the other types like endometrial stroma sarcoma and the leiomyosarcoma, the staging to stage 1 and the 1A and 1B regarding the size of the tumor below 5 centimeter, more than 5 centimeter. Stage 2, it's extend beyond the uterus, but it's still within the pelvis. Stage 2A involving adnexia, stage 2B involving other pelvic tissue, in stage 3 infiltrating the abdominal tissue. It is extend from the pelvis to the abdomen. It's also classified into A, B, or C according it's including one site, more than one site, or it's including pelvic and para-aortic nodal metastasis, which is rare sarcoma. And stage 4A, it's related to the tumors that invade the bladder or rectum. And the stage 4B is cases with distant metastasis. So how to treat? Actually, we said that you encounter these patients mostly after you do the actual management before your assessment. You found that is become myosarcoma after you do hysterectomy or myomectomy. But the standard of care regarding if you have a patient with previous diagnosis that it could be sarcoma, leiomyosarcoma, you can do total abdominal hysterectomy and bilateral salpingophorectomy. This is the ideal for her. And usually these patients receive adjuvant pelvic irradiation. Chemotherapy is or other modalities of adjuvant therapies can be used for cases with advanced or recurrent cases, and we'll discuss this for more in depth. Regarding the surgery issues, we say that the total abdominal hysterectomy and bilateral salpingophorectomy is the standard of care. We do in uterine sarcoma, you should remove in block. Morcellation is contraindicated. So this is the most important. The morcellation debate regarding when you use morcellation and what is your concern during doing morcellation in cases of myomas. We'll discuss this also. The ovaries, regarding if you are going to do preserve ovaries, preservation could be done in some certain patient with early stage uterine myosarcoma that wish they to return the hormonal function. Additional surgical resection should be based on intraoperative finding. But keep in mind that sometimes of sarcomas like endometrial stromal sarcoma and the estrogen receptor positive leiomyosarcoma, it's better to remove the ovaries with the hysterectomy. I think we have a question here. No, still no question. Regarding lymphadenectomy, there is no rule of lymphadenectomy in cases with the uterine leiomyosarcoma or endometrial leiomyosarcoma. Because the evidence of lymph node metastasis is very minimal, below 2% of cases. For inoperable sarcoma or advanced cases, pelvic irradiation with or without brachytherapy with addition of systemic therapy is more recommended. Adjuvant radiation therapy is typically used as it appears to delay the recurrence but does not improve the overall survival. So the first message, avoid morcellation. If you are diagnosed the patient with leiomyosarcoma, go for total abdominal hysterectomy and bilateral salpingophorectomy. We'll discuss about the morcellation. Why we say avoid morcellation in even you are not encounter patient with the leiomyosarcoma or you have not suspicion have no suspicious about this patient to have leiomyosarcoma. Why you avoid morcellation? In 2014, the FDA released the safety communication with the warning regarding the use of electromechanical morcellation device for women undergoing myomectomy and hysterectomy. In this year, FDA warned to use morcellation in patients with leiomyoma. After this report, many criticism was raised for such report. One of these criticisms by the John Hopkins Hospital that do a retrospective study in more than 2,000 patients, and they found only one case of these cases of leiomyomas, that one case have encountered occult uterine sarcoma. They found this, it's very low have leiomyosarcoma. They studied the effect of this morcellation on these patients. What is the effect? Even if they are low percentage, the effect is very dramatic. You have very negative prognostic factor for these patients on survival, and even on local recurrence and disease-free survival. These patients that received morcellation and they encounter to have leiomyosarcoma, they are behave more to have a low overall survival. They are having low and high rate of recurrence. Okay. So in this debate يعني هو بيقول انا استفدت ايه؟ يعني انت بتقول لي ناس النسبه قليله جدا، طب ليه يعني ما انا اعمل المورسيليشن زي ما انا عايز، والناس تانية تقول لك لا، ما هو انت لو حتى لو واحده بس انت كده اذيتها خلاص. ده احنا بس بنتكلم في نقطه بس it is a leiomyosarcoma. There is also another concerns regarding if you do in leiomyoma morcellation, you have another also avoid morcellation if you have any suspicious about malignancy. You have an old age patient, you have a very large tumor, double its size in a short duration time. You have a patient with high LDH, you have a patient with MRI criteria of necrosis, and there is increased vascularity. So what is يعني the rationale to do morcellation in such patients? Go for hysterectomy or myomectomy. It's better, and even to do it with open surgery better than laparoscopic surgery. This is how we use the endobag with morcellation. And this is the endobag that can be used if you do myomectomy. You can retrieve the specimen through endobag transvaginally. It will be a better option. So, as we said, most of cases have been faced after you do your maneuver. You are going to do myoma, and then you found post-operative that is sarcoma. What is your plan after you do morcellation, especially? First of all, if you just do myomectomy, go for hysterectomy. Completion surgery, go for hysterectomy. If you do extrafacial or subtotal hysterectomy, go for completion surgery, remove the stump and the cervix and the ovaries. And you should look for the peritoneum if there is any nodules, if there is any affection of the omentum. Take random biopsies and aspiration cytology to confirm that there is no spread in the intra-abdominal cavity. If you have a patient that encountered disseminated peritoneal carcinomatosis, cytoreductive procedure could be an option. With, for sure, give these patients a systemic therapy afterward. And if every patient with leiomyosarcoma encountered after morcellation, it's better to have an adjuvant systemic therapy afterward with the addition of the radiotherapy for sure. اتفضل.
الاومنتال بايوبسي والبريتونيال بايوبسي لو انه اكسيدنتال ديسكفرد انه يوتراين ساركوما ونو كومبليشن للسيرجري، بس في حال انه انا سسبكت يوتراين ساركوما just enough total hysterectomy and bilateral salvage oophorectomy, or I need peritoneal biopsy and omental biopsy.
If you are going to from the start to do just hysterectomy, and if you have a patient with the uterine mass and you are suspected that is maybe a leiomyosarcoma and you go for hysterectomy, that is enough. No need for looking forward peritoneal biopsy and this as an actual situation. If you have a patient with morcellation before as a myoma and they found that is a leiomyosarcoma, you can go for completion surgery and look for the other peritoneal cavity if there is any dissemination. Okay. Regarding the issue of fertility-sparing surgery in such patients, very limited literature regarding this. Some literature regarding the endometrial stroma sarcoma found that they may some reports that there is they found there is successful pregnancy after fertility-sparing surgery in cases with low-grade endometrial stroma sarcoma or stroma nodule. But still, the fertility-sparing surgery is not an option at all at this time. Still, experimental procedure should not be recommended for women unless after extensively counseled for these women. But till now, there is the option of fertility-sparing surgery is not recommended at all. Regarding adjuvant therapy, although these tumors are high grade, most of these tumors are high grade, extremely aggressive, but the response to the chemotherapy usually are minimal. Observation could be an option in such patient that had done just hysterectomy, and you found this tumor, maybe low-grade endometrial stroma sarcoma or leiomyosarcoma. You can give her an option of observation after complete surgical resection. This is a valid option. So all these studies over a large period of time from 1985 to 2018, most of the results of benefits regarding the adjuvant therapy, chemotherapy in patients with early stage endometrial lower leiomyosarcoma, all of these cases found this are of low or less benefit regarding the overall survival and disease-free survival, progression-free survival. There is no difference if you give this patient chemotherapy or just observation. So, especially in patient with early stages leiomyosarcoma, you can give her an option of observation following the surgery. You can give her for sure adjuvant radiotherapy. Okay. What are the agents that commonly used? Are doxorubicin, docetaxel, many single agents or combination chemotherapy have been studied. Overall, the response of the chemotherapy is poor. Usually, we give chemotherapy for more advanced cases. Okay. The most recommended adjuvant first-line treatment is anthracycline-based chemotherapy with dacarbazine and ifosfamide are recommended as a first line of treatment. And according to the response, you can give here a second line or not, according to the response of the patients. So when you give adjuvant chemotherapy, it's given in patients that you suspect a higher risk of recurrence. That is, patients have a high mitotic index, patients with tumor size more than 5 centimeters, and as we said before, patients that received morcellation before. Every patient that have been diagnosed after morcellation, it's better to give her combined chemotherapy after you do the completion surgery. So regarding hormonal therapy, as we said, the endometrial stromal sarcoma found to have responding to the hormones and hormonal positive leiomyosarcoma. So you can do ER testing regarding the after the hysterectomy on the leiomyosarcoma, and you can give her aromatase inhibitor or gonadotropin releasing analogs as a treatment for this tumor after the hysterectomy for sure. And you can give her a first-line hormonal therapy, second-line hormonal therapy according to the response of the or there is recurrence afterward or not. If the hormonal therapy fails and the patient show recurrence, you can give her systemic combined chemotherapy afterward. So in advanced and recurrent disease, in some cases with advanced stages of sarcoma, the surgery remain and the best option if it's feasible for sure. The aggressive cytoreductive surgery seems to be associated with increased progression-free survival, but not the overall survival. So you should have a high selected patient for such doing highly morbid surgeries. And you should select your candidates that need addressed carefully and to add improvement in the progression-free survival, and you just wait the benefits against the morbidity of surgery. Regarding the recurrent setting of the tumor, few evidence that support surgery in such condition. It's better to give her systemic chemotherapy. Some studies have been done on HIPEC, intraperitoneal chemotherapy, and they found a very promising results, but we have very limited studies in this issue. Recently, the novel targeted therapy, such as bazobanib and the immune therapy or checkpoints inhibitor like pembrolizumab, have been investigated in advanced and recurrent disease, and they found there are quite promising results in such patients. So we can give patient hormonal therapy for hormone receptor positive or endometrial stromal sarcoma. We can give combined chemotherapy for advanced cases, and in advanced and recurrent cases, we can use targeted therapy and immune therapy for sure. What about the neoadjuvant therapy? Although, as we said, they are aggressive tumor, they are high grade. Theoretically, if we give chemotherapy, that could make the tumor shrunk enough that you can make your surgery feasible, but that theory is not actual in the real life. Very limited regarding the response to the chemotherapy is very poor in such disease. And you cannot predict the tumor. There is heterogeneity in these tumors. You cannot predict the grade of the tumor, the typing of the tumor, and for sure the response of chemotherapy as a neoadjuvant setting. Okay. The prognosis, as we said, sarcomas are poor prognosis. They are differ also regarding the extremity sarcoma. I think they have a very good prognosis when you compare with the uterine sarcoma. In a study that they found the 5-year survival rate according to the stage and the size of the tumor. If the tumor stage 1, it's the survival may be more than 50%, and it's become less than 3% if the patient have a stage 4 uterine sarcoma. Oh, للأسف. والrecurrence very high. ايه adverse prognostic features that you can suspect that how your patient will behave if the patient have a FIGO stage more than 2, the age of the patient more than 50, the tumor size also affects the prognosis, the negative progesterone receptors status, the high mitotic count more than 10, and the high preoperative C-reactive protein more than 3.5 millimeter per deciliter. We'll discuss these issues, the STUMP, the DBL, and the parasitic myoma. Okay, I'll look for if you have any question in the first partition. No questions. Okay. I hope you are understanding me. اعمل ايه؟ اقلب ماشي. مفيش حد هنا يعمل لي next. Okay, we are discussing the STUMP, the DBL, and parasitic myoma because they are in relationship with this condition. What is the STUMP? We discussed it at first of our lecture. STUMP is in between the leiomyoma and the leiomyosarcoma, like borderline ovarian tumors. It is the term referred to smooth muscle tumors of uncertain malignant potential. Indicate a group of uterine smooth muscle tumor that cannot be diagnosed unequivocally as a benign or malignant. They are in between benign and malignant. Okay. How? Okay. The STUMP, it is a group of tumors of a smooth muscle tumor that arise from the smooth muscle of the uterus. Okay. This group of tumors have uncertain malignant potential. Okay, it is not benign and also not malignant. It's in between benign and malignant. Okay, and we'll discuss what is main of uncertainty. Pathologically speaking, how to differentiate between, or you can diagnose leiomyosarcoma or leiomyoma. It is depend on three main characters: the atipia, the mitosis, and necrosis. Okay, these three criteria can diagnose. The pathologists use this criteria to differentiate if you have a smooth muscle mass in the uterus, either it's be leiomyoma or leiomyosarcoma. If there is atipia, diffuse, moderate to severe atipia, mostly this is a leiomyosarcoma. At least two of these criteria is enough to diagnose leiomyosarcoma. Okay, if the patient have mitotic figures more than 10, this is also more to be leiomyosarcoma. If there is necrosis, which is one of the main criteria, the coagulative necrosis is not other types of necrosis like hyalinosis or other types. The coagulative cellular necrosis. If there is coagulative cellular necrosis present, it's mostly a leiomyosarcoma. While these criteria are absent and the mitotic figures is below or equal 4 in leiomyoma. So where is the STUMP? The STUMP, as we said, it's in between. It contains some criteria of leiomyoma and some criteria of leiomyosarcoma. And this is called these criteria, the Stanford criteria in histological diagnosis of leiomyosarcoma, the Stanford criteria. Regarding these criteria, they classify the STUMP into three main categories: atypical leiomyoma with low risk of recurrence, atypical leiomyoma but limited experience, and the smooth muscle tumor of low malignant potential. You found in the first one, the atypical leiomyoma with low risk of recurrence, the mitosis is below 10. It's not more than 10, but it is still higher than the leiomyoma, more than 4. They contain fuse atipia, like the sarcoma, but there is no necrosis, like leiomyoma. The other type, the next one, have a higher mitotic index, below 20. There is severe atipia and absent necrosis. Okay, the last one, the mitosis is below 10, and there is no atipia, but and there is no necrosis also. Positive necrosis. The last one, there is necrosis, and there's, as I said, necrosis is one of the main criteria of sarcoma. So the last one have a low malignant potential. The low classification, the lower one of the STUMP have a low malignant potential because of the necrosis is present in such type. Okay. As we said, the STUMP is in between the leiomyosarcoma and leiomyoma. It behaves like leiomyoma, that is, this tumor is slowly growing. This tumor, the less aggressive than leiomyosarcoma for sure, does not tend to metastatize severely, but it have the ability to recur, especially if the patient had done myomectomy. But as we said before, in the borderline ovarian tumors, in such disease with such condition of that it is slowly growing, it is not behave like malignant, and also have some criteria of malignancies of local recurrence. In such condition, you can just spare. You can do not be aggressive in such tumor. You can offer patients with this condition a fertility-sparing option for sure. Okay. As we said, the diagnosis of leiomyosarcoma is difficult, and the STUMP, it's quite impossible to diagnose STUMP before doing hysterectomy. It's usually remains, and after you do myomectomy or hysterectomy, you diagnose the STUMP. Okay, if the patient received the STUMP, received a post-myomectomy option, and you found this is a STUMP tumor, according to the counseling of your patient, according to the fertility desire of this patient, according to the age and the performance status, you can counsel your patient either to do just fertility-sparing surgery and offer her fertility-sparing option, or go for completion surgery to avoid the local recurrence. Okay. The reported recurrence rates is quite large, from 7 to 27%. the recurrence ratio after hysterectomy and myomectomy is similar. If you've done hysterectomy from the start, the STUMP recurrence is similar to the myomectomy option. Recurrence of the STUMP, like borderline ovarian tumor, may recur as a STUMP and may recur as leiomyosarcoma. In borderline ovarian tumor, it may recur as a borderline or may return as low-grade epithelial cancer. Okay, serous carcinoma. Okay, the treatment option of recurrence, in addition to surgery, include adjuvant chemotherapy, radiotherapy, or hormonal therapy, and like progestin and GnRH analogs. The 5-year survival is quite high. It's above 90% to 100%. The remaining problem is the local recurrence, and I think it's not a big deal. Unless the patient wants fertility, they can offer her fertility-sparing option, and afterward you go for hysterectomy. Okay. So what is the DBL? DBL is a disseminated peritoneal leiomyomatosis. Disseminated peritoneal leiomyomatosis. From its name, you have dissemination of the leiomyomas all over the peritoneal cavity. Okay, it is a rare benign disease, often giving appearance of peritoneal carcinomatosis or ovarian cancer with metastatic metastasis into peritoneal cavity. The estimated prevalence of DBL is about 1 to 10 million or million. Okay, it's first described by Wilson and Bale in 1952. Okay. Regarding the theory how DBL present or actually appear, it may arrange or originate from the metaplasia of subendothelial mesothelial multipotent mesenchymal cell. There is some cells in the submesothelial layer of the serosa covering that may originate and the metaplasia on this cells can originate the DBL. Although it's not clear what is the stimulus for this and how the process is undergo, the smooth muscle differentiation is hormonal or maybe genetic or both. Maybe a stimulus, a genetic stimulus or a hormonal stimulus. Also, as we said before, to avoid morcellation is found to be an induction, or this condition can be induced by the morcellation. If you do morcellation and you spread the myoma cells in the peritoneal cavity, this may result in DBL. It affects women in reproductive age group, very few cases in postmenopausal women, and also reported few in men. مورسيليشن احنا قلنا سيرته في الاول، ده جهاز بستخدمه عشان اقطع الميومه لو انا بشتغل باللابروسكوب، بفرمها كده خلاص، مفرمه. طبعا مفرمه جوه البطن في البروتونيال كافيتي، اكيد حتى لو انا حريص قوي شويه هيجوا على البروتونيال سيرفيس. لو فيها ساركوما دي مشكله كبيره، لو هي اصلا ميومه ممكن تعمل لي دي بي ال. فاحنا قلنا الكونسيرنز regarding morcellation is to do with precaution and to do in endobac it will be better option. Okay. So how to diagnose the DBL? By ultrasound or MRI. There is hypoechoic nodule. In MRI, it's hypointense in T1 or hypoiso hyperintense in T2. But the main differential diagnosis, if you have a report of DBL, you may suspect that it's maybe peritoneal carcinomatosis, spread of leiomyosarcoma, or how to differentiate this condition from the DBL. This is the question. On CT, these lesions appear to be well circumscribed, solid nodule, and the adjacent peritoneum is usually normal. There is no thickening in this peritoneum, and there is no abnormal enhancement in such lesions. Okay, they are like myomas just under the peritoneum, and covered by clear peritoneum, not thickened. And on the other hand, the peritoneal carcinomatosis usually associated with ascites, peritoneal thickening, increased enhancement, peritoneal nodules, omental nodules, caking, and also there is bowel thickening, and there is an adenopathy. While ADBL, there is no affection in the peritoneal surface or bowel surface. There is no adenopathy. There is no ascites. Okay. If you have a patient with disseminated leiomyosarcoma, these lesions appear in the PET-CT as hypermetabolic if they are leiomyosarcoma. If they are DBL, they will be isometabolic to differentiate between DBL and disseminated leiomyosarcoma. اوكي هيساعد في الدايجنوز. تمام. الميكروسكوبيك examination for sure. If you do surgery and you just take a biopsy from this nodule, we found this lesion have no atipia. There is no stromal invasion with or without low mitotic activity. Okay, like myomas. Okay. The treatment guidelines, there is no standard treatment guidelines because we have a very low number of patients. And the treatment is individualized according to the patient condition, the patient age, the patient symptoms, and the performance status of your patient also. According to the symptoms, if the patient have no symptoms, usually requires no therapy. If you can give her a hormonal therapy, either medical castration or surgical oophorectomy. You can do debulking or surgical excision of metastatic nodules in patients with large symptomatic DBL. Hysterectomy is considered a patient with uterine condition. If the patient has associated myomas in this condition, you can do hysterectomy. But if there is just DBL, there is no need for hysterectomy. In postmenopausal women, aromatase inhibitor has been used with success to treat non-resectable tumors. Okay, this is how you manage DBL, and it is similar to the parasitic myoma, but with large size. Okay, the parasitic myoma you found in this picture. This is the hysterectomy with the large myoma, and beside on the left side is a large parasitic myoma with abnormal vasculature surrounding it. The parasitic myoma is a rare variant of gynecologic entity. It's classically defined as how it presents. Usually, the theory that it is a large pedunculated subserous fibroid that is detached from the serosa of the uterus and become implanted in the nearby organ and receive a new vascularization. Okay, this is one of the theories. The other theory, or induced by also the morcellation. So avoid morcellation to avoid the spread of sarcoma, and avoid morcellation without precaution, especially to avoid DBL and parasitic myoma. I hope you found this lecture is quite beneficial for you. Thank you. If you have any question, please feel free to ask me in the Q&A box. And also the audience, if you have any question, I'm happy to answer. Okay. عندك سؤال يا I'll see if there is a question in the Q&A. Actually, I have no question. We have a 23 participant. Okay, I'll see in the chat. هو ما بيفتحش ليه؟ دكتور باسل بيقول زي الفل. اتمنى يا دكتور باسل تكون في الساحل واحنا هنا في المسحول، مش مشكلة. يا رب تكون انت كمان زي الفل. في ايه؟ Okay, the next week we'll happily have Dr. Basil Rifqi, the next lecture. It's about fertility-sparing surgery options in gynecologic oncology. I think, and for sure, it will be interesting lecture with our beloved Dr. Basil Rifqi. Thank you all, and see you next week, inshallah. Thank you.